We have three incredible experts to speak to you today. I'm going to introduce all of them, and then they will speak in turn. I'll ask if you can hold your questions to the panel discussion at the end. So Dr. Carolyn McGregor is the Dean of the Faculty of Business and IT at Ontario Tech University. Previously, she held the title of Research Chair in Artificial Intelligence for Health and Wellness, and she's a two-time Canada Research Chair in Health Informatics. She is the founding director of the Joint Research Centre in Artificial Intelligence for Health and Wellness between Ontario Tech University and the University of Technology, Sydney in Australia. She has led pioneering research in big data analytics, AI, deep learning, real-time stream processing, temporal data mining, and cloud computing. She now progresses this research within the context of critical care medicine, precision public health, mental health, astronaut health, and military and civilian tactical training. She was named a Women Leader in Digital Health by Digital Health Canada and is a member of the Order of Australia. Dr. McGregor has over 190 refereed publications, 3 patents in multiple jurisdictions, and has established 2 startup companies from her research. She has research collaborations across the world. She has also provided strategic consultative support to Ontario Show's Centre for Mental Health Services and Providence Care in the area of patient journey modelling. She currently leads 2 research studies on the International Space Station for new approaches to astronaut health monitoring. I think you can see why we have invited Dr. McGregor to speak to this topic. Please welcome Dr. Carolyn McGregor.
Well, good morning. Thank you very much, Robin, for that wonderful introduction. I've had the pleasure of working with neonatology and other areas of healthcare, not as a clinician myself, but really turning up, going into the hospital and learning to try and make contributions today. So today, in terms of the learning outcomes, my area is focusing on big data and within that context of artificial intelligence, and you'll see where I'm talking about not just working with large volumes of data, but really data that come from sensors. But I know that these other topics are covered off, but I do talk in my presentation about biological sex and gender and its impact on AI, and also about deployment, because all of these are the real challenges we have in the area of AI as well. It's a shame you can't see this very well, but I encourage you to look it up online. It's a magazine cover. It's from 1924, which I was really excited because I've been speaking about this for a few years, and we finally reached 100 years from when it was. So what are they showing actually in the image? It is a current technology at the time rendition of how you would provide rural or remote care. So the idea isn't new. I'm sorry to burst that bubble. If you read the article, which you can do with the joys of the internet now, they have scanned and made this whole magazine available online. You will see that it is fully architected using the technology of the day. But they did it as a joke, quite seriously. They did it as a joke because they couldn't understand why the patient and the clinician would not want to be in a room together. Why would you do this thing called remote care? So technologically, we've had the ability to transmit data, we've had the ability to provide this visual virtual experience for a long time. What we haven't been able to do until more recently is actually store the data and store it well. And then when you have it stored, what can you do with it? So just to give you an idea of scale, this study was completed and published in 2019. It was saying then how many articles were being published on artificial intelligence. And it's broken down by a number of different categories. So the bottom scale is around 400, goes up to, like neonatal, there were only 10, orthopedics 47, just to give you an idea, up to 2019, who was using AI in their title and in their study. Just in the last couple of years, the number for neonatology has gone from 10 to 848 published studies, and in adult care it's now up to 23,000 and growing rapidly because people are like, oh, I need to put that word in my title. So we've been using it in my area for a number of things. At Ontario Shores, this was part of a strategic initiative back for them in 2017 when they were formulating it even in 2016. We need to think about how we use data. We need to think about how we use technology. So there's 3 areas that I've been using artificial intelligence with Ontario Shores to perform research. Before I go on any further, artificial intelligence in its simplest form is not using the human brain to investigate something. So, there's lots of ways you can further describe that, but broadly, and that's why we say using a computer is artificial intelligence. Is statistical analysis broadly in artificial intelligence? Many would say that it would. And then there's things like machine learning. Well, they're particular techniques that we might use on the data, and deep learning, a subset of that as well. But we have to scope what AI is and what AI isn't. So with patient wait times, we gathered the data and we had a look. What could we learn and help them to learn? Because they didn't understand and know about their patient wait times. But they were the first hospital mental health facility in Canada to get to HIMSS level 7. So they had the data. So we went and had a look. So we performed that type of research. We've also been collecting data from the daily observations of the patients. We found that the highest quality we had was in the geriatric dementia environment. So we're looking, if even from those daily observations, are there trends and patterns we can see in their vitals that are being collected every day that meant that they were more or less associated with potentially having aggressive behaviour. We can have a look and see what we can find. And then the last one was actually measuring the physiology of staff and the nurses who are dealing with patients who are becoming aggressive. And I was able to cross-pollinate this from my work with tactical officers because I learned that when the heart rate gets too high, you have fine and gross motor skill failure and also issues with cognitive function. So they're not able to think through the steps that they can use for de-escalation if their heart rate's getting too high. And what can we learn from their own heart rate? So there's many examples that I can give you of what we're doing with artificial intelligence. My main project for a number of years has been in neonatology, why I started to know Robin as well. I started to look at the fact that there was a whole lot of data in this context that was just being lost. These machines generate a fire hose of data, 1,000 readings a second electrocardiogram, 128 readings a second for plethysmography, depending on the device, lots and lots of data. And it was scrolling out of memory. And systems weren't able to make sense of that at such a speed. And I found that an interesting problem, motivated by my own personal journey with premature birth of one of my children. And I wanted to try and create a system that we could gather that data. And then when we had it, have a look at it, create new techniques to look at it, and then see how we could contribute with these new forms of detection of pathophysiology of disease and conditions. Ultimately, because there are these children in neonatology that seem to just be feeding and growing, and in a couple of hours they're close to death with sepsis. So I wanted to see how I could contribute. So all this is a form of big data, which to me is sensor data. There's lots of different sensors we attach to patients. There's environmental information. We sense it every second or 1,000 times every second. And the quality is different. In neonatology, what was great is babies are left to sleep for many hours at a time. They try and bundle interventions. So we had good quality data, which you don't always have in other areas. So we ultimately have been investigating 7 different conditions for neonates, looking at what we see. So this is what led to the new patented technique that I developed. Can you align the events that are the same events when they're diagnosed with late onset neonatal sepsis, diagnosed with necrotizing enterocolitis, diagnosed with early onset neonatal sepsis, and apnea of prematurity? Can we detect those things? And what can we see in the data in the time leading up to that diagnosis? And people often talk about, well, AI, we're trying to build prediction. And I say, well, it's not actually prediction in my case because we're actually detecting things. We're using scientific techniques to actually prove and show that there's not just a correlation or there's a causation and a flow, that this is pathophysiology. And we're really trying to tease out what it is about that particular behaviour. So we're detecting things. Now, you can say there's situations in public health models where you say that, there's this percentage of this occurring if you have this, if you are a smoker or if you are this or you're that. That's more of a probability analysis. So I think some of the things we have to look at is that terminology, because for me, I'm doing new forms of detection that are scientifically based. So some of the things that we've been able to do is that we use what's called exploratory techniques, and we look at the data and we see where it's clustering together, but we start to then use what we call explanatory techniques, so we understand what it actually is. And this is an example. So when we were looking at this neonatal population, we looked at heart rate variability and respiration rate variability, and we were able to group it based on certain conditions. So when the heart rate variability drops, it could be a couple of things. We found that it could be that they're developing infection. We also found it could be that they've been given certain sedatives. But we also found that it could be that they need a blood transfusion. But what was interesting is all of those could-bes had different behaviours in heart rate variability. And when you coupled it with respiration rate variability, it helped again to tease out what actually the behaviour was in that particular situation. So we're using data, we're creating new techniques, we're exploring what we see as associations, explaining it, looking at it in certain context, and actually then applying null hypothesis testing to the scenario. Are these the only situations where this particular pattern existed? And in my most recent study, we were doing that with a population of over 240 neonates where we've been collecting data. But we've collected data of thousands. This is some other analytics that we're able to provide, again a little hard with the lighting. It's hourly summaries of second-by-second analytics of whether heart rate, respiration, blood oxygen saturation and blood pressure are behaving the way we think that they should. And if heart rate doesn't, it turns light blue. If blood oxygen doesn't, it turns yellow. And then those two plus, what have I forgotten, blood oxygen, respiration and blood oxygen, heart rate, then it's yellow. So you can see on the right-hand side, it starts to go yellow. More of the time of the hour, it's yellow. The second hour from the right is when it was detected at the bedside, and there was suspicion of LONS. So you can see that this was telling us there's other pathophysiology unfolding that's not as evident to the naked eye. And then this is another one for tracking blood oxygen compliance. We need to have blood oxygen in a certain range. This is still an open area of research about cerebral palsy and ensuring enough blood oxygen saturation for healthy development. But this allows them to see where was the child hour to hour. So we can do these types of analytics. All of this running in real time outside of the hospital to show we can provide this support anywhere in the world and even off-world. These are digital twins. You might hear that term. But even from 100 years ago, if you were sitting with a clinician and they took your heart rate every 6 months, that's still a digital twin. It's not a very clear digital twin, but it's still a twin of who you are. What we're able to do in this, the old style of digital twin also was, I have a model or this notion of a human being, this notion of an airplane engine. Now we can track every individual instance, which makes a difference. But there's some other things that we've been able to do. We think about how we can automate, and with a comment about ChatGPT, we think about the fact that physicians, clinicians spend a lot of time trying to learn and understand latest scientific evidence, how to integrate that into clinical practice, so reading a lot of journal articles. And it makes you think about, well, how do we try and automate that? And I'll draw an analogy from, and it's hopefully you can see, but this is a robotic attempt, modern diagram of what was being done in the past when they tried to create a dishwasher. The first attempts of a dishwasher were to mimic what the human was doing. So they had all sorts of, in the time of the era, these mechanical arms that were trying to pick things up and wash them. And then all of a sudden someone said, hang on a minute, what we're actually trying to do is wash dishes. So let's think about an efficient way to wash dishes. And that's what they came up with today. And the same thing is what's unfolded, if you think about it, with what we now are utilising ChatGPT for, because people have taken a step back and gone, hang on a minute. We don't actually just want to give journals to physicians and surgeons and clinicians on an iPad. We actually want to help them to fundamentally answer questions that they're trying to answer, which has led us to what we've been doing today with these large language models. So creating that way to have that interface to ask a question, to interpret your question, that's one part of the technology. And then creating the way to then go off and gather the information in the right way. That's another piece in the puzzle. We've actually had these types of large language models for a while. I learned how to build them on the dark ages when I was at university. So I learned about ELIZA and all of these other ones as we went on in time. The difference is the accessibility of ChatGPT and the way that it can be written so that it can go out now through the internet and get to things. But we were trying these techniques for some time to understand what someone was asking and understand how to action it to then go and get the computer to do something. But one of the challenges we have is reliability of information, because if you don't tell ChatGPT to actually use articles as references, it'll make up the idea of a reference because it doesn't know any different. And so people need to understand what these tools are doing and what they're not doing in order to understand how to utilise them. This diagram, perhaps a bit complex, is showing on the left-hand side that it can learn how to have a conversation. It can learn language from a larger corpus, but then it needs to learn medical knowledge from a smaller, curated content area. And then you're having the conversation and it's understanding language, but it's getting the medical information from somewhere that's been curated. So these are the types of models that are being constructed at the moment. This is an NHS initiative called OpenGPT, and the analogy, funny enough, with these two people who are leading PSI is a scenario for a differential diagnosis for a 35-year-old woman with abdominal distension, nausea, vomiting, and just the different diagnosis, one of which is that she's pregnant. So these are the types of tools that are coming online. What's interesting, ChatGPT took the neonatal board exam a few months ago. It was 3.5 version of ChatGPT. There were 936 eligible questions. What's interesting is what I've highlighted down the bottom, though, is that it performed poorly on multi-logical questions. It was best on recall and basic clinical reasoning because it can go and look for things. It's that inference part that's still difficult. But it had significant issues with factually incorrect answers and errors and omissions, so it's still not really there. But what's interesting is if you put a humanoid avatar in front, people think, oh, I can trust that because they look like a human. All we've done is stuck that humanoid technology in the front of all of these other pieces, but all of a sudden it becomes something people will trust more, which is something that we all have to keep in mind. And other things we have to think about is how, this diagram is a bit complex, but how we interface with who's actually on service, who needs to receive information at any given point in time. So this is something also for you to think about. It's a book called Crossing the Chasm, How We All React to Technology. How many people have the, the iPhone 16? Has it come out now? Is it available? Is it actually available to purchase? But who has to have the latest and greatest? I know I've just got the, not dropping names, but I've got the latest e-ink notebook that I'm using. I won't go into specifics and names because I'm trying out the technology. So I'm either an innovator or an early adopter in some things, but where are you individually and where is your healthcare facility? Because that'll impact how you respond and think about technology and whether you trust it, how you explore its functionality. And it turns out what influences people is whether they think it's mysterious, how much they understand that human interface, because people feel more comfortable if there's a human interface. And oddly enough, the more complex people think a system is, even if they don't understand it, the more they think it must be good because it's complex. So that's ironic. Just quickly finishing up on some other areas, we do have to consider bias in the way we interpret data, the population that we're serving. One of the things with my astronaut study in space, I'm one of the first people to actually study biological males and females and how they adapt to space. A lot of the research in the past has been on white males. So I'm looking at that in a different context. Race, we don't systemically collect race information. We need that because we know anecdotally there's been a lot of evidence to say that race can impact certain conditions, but in the electronic health record it's not there. That causes us a problem. And you've got to look at the mismatch of when you look at a study and you look at what they've performed, what was the population and is it relevant for you as well? I get asked a lot, Are we trying to replace doctors? No, I'm certainly not, and a lot of us aren't. There's still that role for that human connection. Humans are better still at the visual interpretation, particularly of things like graphs over time. Humans are still better to be able to do those interpretations. So this is all part of my work on analysing humans in extreme settings. So as Robin mentioned, yes, I really do work with tactical officers, firefighters, neonatologists for neonates, astronauts, and also with professional divers. Hope you found it interesting, and thank you.
Well, that was terrific, thank you. And you've already launched us into space, so. Our second presenter, Dr. Alex Mariakakis, is an assistant professor in the Department of Computer Science at the University of Toronto and an affiliate scientist at University Health Networks Techna. His work identifies applications of machine learning and computer vision on sensor data for human-centered issues. Dr. Mariakakis' primary research is in mobile health, leveraging smartphone sensors to objectively measure symptoms that are typically judged qualitatively. His current research program seeks to combine passively collected sensor data with momentary assessments to support Bayesian diagnostics in contexts like influenza, Parkinson's disease, and mental health. Dr. Mariakakis received his PhD in computer science and engineering and also completed a postdoctoral fellowship at the University of Washington. His work is published in top-tier venues in his field, including the ACM Conference on Human Factors in Computing Systems, as well as the ACM on Interactive Mobile, Wearable, and Ubiquitous Technologies. His work has also been featured by many media outlets, including the BBC, National Geographic, and USA Today. Dr. Mariakakis is a recipient of the National Science Foundation Graduation Research Fellowship, the Qualcomm Innovation Fellowship, and the Gaetano Borriello Outstanding Student Award at UbiComp 2018. Please welcome Dr. Mariakakis.
Good morning, everyone. This is really exciting for me. I really appreciate being here because as a computer scientist, I work with clinicians a lot, but this is the first majority clinician audience. So that also means this is the first time I've ever had to make a slide like this that discloses my funding. So, of course, I have work that's funded by NSERC. I do some research collaborations with Google that I'll allude to a little bit later. And then you can see that there's other funding sources near the university. So today, of course, I'm going to be talking about how we can use AI in health, as all the other panelists are talking about. But specifically, I'm going to be talking about wearable devices and thinking about not just what we do with the data, but how we get the data. And from my particular research area, I'm looking at unique ways that maybe normally people don't think about generating data. I'm sure many of you are familiar with Fitbits or Rings, these devices that are providing very rich data related to sleep and heart rate monitoring, for example. But I'm going to be talking about some innovative ways that maybe you haven't been thinking about using sensor devices or devices that normally aren't considered sensors. So this is a question I like to start my talk with, and again, it's interesting to do with this audience, and I'm not going to do a whole back and forth exercise with you all, but I'd like for everyone to think about the last time that you saw your doctor, as a patient, not as a colleague, because I already know that answer. And I'll put an example timeline for the sake of saving time. This may be, depending on how you look at this, maybe this is optimistic, maybe this is extremely pessimistic, right? Maybe you have someone that has a yearly checkup where they get, very basic physical checking very basic vital signs like heart rate and whatnot. And maybe for better or for worse, there's some sort of unfortunate accident where you go into the emergency room, maybe you broke your foot, some sort of medical incident, right? The thing I want to highlight here is that there's two kinds of gaps that I'm showing in this timeline. First, there's a gap in time, right? I'm not at the doctor all the time. I'm not going to argue that we should be at the doctor all the time. We know why we don't want to do that. But there are gaps where, as a patient, I don't really know what's going on with my health. And that could lead to uncertainty. That means that we can miss issues before they start building up, and this can create some problems. Now, the other gap that may not be as obvious is I don't really have a good idea of all aspects of my health. If I break my foot, I'm not going to get blood work done, so I'm not going to have some sort of updated information about that aspect of my health. And even if I'm doing some sort of general workup, I'm not going to, if I'm at a high risk of, say, pancreatic cancer, I'm not going to get my bilirubin tested all the time unless that is a highlighted concern in my health record. Now, there's many different reasons why these gaps exist, and I'll talk about a couple of them, but I'm sure you all can think of many others. So, I'm from the United States, so the obvious thing that comes to mind is money, right? This is a statistic I pulled from 2015. I'm sure the number is higher at this point, but the number says that the average uninsured American pays $160 for each primary care visit. That may sound small to some, but of course they could be disproportionately burdensome to people who are financially disadvantaged. Of course, we live in Canada, so the thing that everyone likes to point to is long wait times, right? This idea that I mentioned earlier about having people constantly have their health checked can be very problematic and scary from a clinical side when you're already overburdened with the number of patients that you're seeing on a daily basis. And of course, there's also issues related to equity in the terms of proximity, right? So a lot of people like to point to statistics, at least in my field, of number of doctors within a given area, right? Number of doctors per country, for example. But doctors are not distributed equally across an entire geographic region, right? So I did my PhD in Seattle, Washington. Very fortunate to work with lots of hospitals, have lots of doctors. The rest of the state, Western Washington in particular, do not have the same kind of density, but that number can be glazed over in some cases. What these gaps and many others create is a reactive healthcare system. Because of these gaps, we don't know what's going on with our health, and then some sort of incident happens, and we have to react to that incident. So what my research does, and I'm sure AI in general for all of our speakers as well as others here today are probably striving towards, is a proactive healthcare system where we can identify issues in advance, treat them early, hopefully have better success. Now, the way that my particular research agenda tries to address this is by using what I call ubiquitous technologies. Ubiquitous being pervasive, all around us, the things like our smartphones, wearables, smart rings, even new devices that are coming out, basically sensor packages, if you will. To that point, there are lots of sensors on these devices that you may or may not think about, right? So there's location. That is a sensor, and that could give us useful information. Is the person getting out and being social, or are they staying put in their bed the entire day? We can look at audio and motion data to see, again, are people being physically active? Are they talking? Later, I'll be talking about some speech analysis that we've been doing. So audio, a microphone is a sensor, even though phones are really just used for calls normally. And even light and camera. So I'm sure many of you have seen vision-based technologies that are analyzing images. MRI images could be an example, but even just a picture of someone's face can give us some information about their health. Now, we could take all this sensor data and then use algorithms, digital signal processing, computer vision, whichever buzzword you want to use, and we could generate different kinds of health indicators. And I like to think about 3 different categories. The first is contextual indicators, so mood and sociability. The second is behavior, so things like physical activity and sleep. And finally, physiology, so things like heart rate and cough rate. And we could generate these numbers, and we already see that some devices are generating these numbers. So Fitbit, for example, they don't give you the raw measurements from a light sensor. They give you a heart rate variability, and then they go an extra step. They get to some distal outcomes or high-level outcomes. So in the case of something like Oura Ring or Fitbit, you might see these things like wellness scores that are just some sort of aggregate statistic or summary statistic of those underlying measurements. But you can also think about trying to infer other outcomes, so things related to respiratory diseases, aging, and psychological well-being, for example. Now, Dr. McGregor had already mentioned this, and I, as a computer scientist, like to make sure I have this warning at this part of my talk, which is I'm not here today to say that we're going to replace doctors with these kinds of technologies. That would be horrible, and I could go on a long rant about this, but obviously we're trying to augment their capabilities. And as a computer scientist, I'm here to say that while many of my colleagues like to talk about these kinds of technologies in terms of diagnostic screening, so this idea that I could have someone download an app and get a cancer diagnosis of skin cancer using an app, that sounds really great, but it's also really scary to me. But that doesn't mean that the research needs to stop. There's plenty of other applications where this technology can be useful. So disease management is another application that comes to my mind. So rather than just having people download apps and get diagnoses, can we have this situation where we already know someone has a medical condition, but they need to monitor their vital signs or some aspect of their health over time? Going back to that example I talked earlier about filling in the gaps of the data. And not all of the applications of mobile health necessarily have to do with disease. Sometimes people just need to know some aspect about their health, this general idea of wellness. So I'll be talking about menstrual health in a little bit, and that's a case where menstrual health is not a bad thing. Over half the population experiences it. So it's a matter of, can we help people just understand their bodies a little bit better? And with all these applications, human-centered design is really important. And the example I love to give about this is a weight scale, which is a very simple form of a diagnostic, not diagnostic tool, but a medical sensor, right? I could stand on a weight scale and it could say I weigh, I'll give myself a little bit here, let's say 200 pounds, a little bit, definitely over that. Let's say I weigh 200 pounds on Monday. I step on the scale the day after and I weigh 205 pounds. Depending on a person's numeracy and their personality, they might say, oh my God, that's a linear trend. I'm gaining 5 pounds every day. I should go change my lifestyle. But we know that that's not the case. There's lots of different things I could go on. Sensor uncertainty. I wore an extra t-shirt. I had a big meal. I was extra hydrated. But not everyone is aware of those kinds of nuances, and they may go to extreme conclusions. So what happens if we start building technologies that aren't just measuring our weight, but they're saying that we have skin cancer, that here's a whole bunch of numbers that you need to pay attention to on your Oura ring. I'm sure many people fixate on some numbers related to sleep tracking, for example, right? So that's something really important that I try to consider in my research. So this is the poster that I like to share from my research group, and there's a QR code hopefully you can see at the top right if you're interested in looking at all of the projects. But I run the Computational Health and Interaction Lab at the University of Toronto, and I already have the spiel up at the top that we use ubiquitous technologies for these kinds of problems, and I like to say that our research group works in 3 main areas. The first has to do with momentary health assessments, so this idea of maybe taking out a device like a smartphone or an earable, and then getting some sort of measurement of your health. The second involves continuous health sensing, so not having to have someone take out a device, but just having the device kind of listen to some sort of information and then be able to infer aspects of health. And then finally, interactive design. So this piece of saying, great, we can build all these technologies, but how do we present that data to people? How does it get integrated into a clinical workflow? Things like that. And I'm very briefly going to talk about one project in each of these categories. So for momentary health assessment, the project I like to talk about has to do with using acoustic cardiac sensing with earbuds. So how many people have wireless earbuds here by any chance? Good number of people, right? So this is kind of a burgeoning, ubiquitous technology that is becoming very popular in my field for sensing, both for interaction and even for health. So you might be aware that there's microphones inside those earbuds. In fact, there's not just one microphone, there's 2 microphones. One that points outside the ear to listen to the background sounds, and one inside the ear to do active feedback noise cancellation. And it turns out that this internal microphone, given the right conditions, can actually hear your heart rate. Sounds a little, your heart sounds, I guess, if you will. It sounds a little crazy, but if I were to ask you all to stand up right now, do 15 or 50 jumping jacks, depending on how fit you are, and then you paused, you probably remember in some cases when you've worked out that sensation of feeling like you can hear your heartbeat. And there's lots of different papers that make different claims about why this is. There's a combination of the pulse basically expanding arteries near the ear, or in some cases maybe direct sound transduction. But the point is that it turns out these earbuds can actually pick up on this very subtle signal. So what we've been doing is we've been looking at, as a research group, what can we do with this signal, right? We can measure heart rate, that's great, but can we actually generate a signal that's actually similar to a digital stethoscope? Because if you're imagining that in the remote healthcare scenario, like the radio doctor that Dr. McGregor showed earlier, if I give someone a digital stethoscope and say, place it on your heart so I can hear your heart signal, people might have trouble getting that signal. It's not the easiest thing to do. At least I struggle with it personally. But if I ask you to wear an earbud, they're kind of engineered at this point so that there's only so many ways you can wear it. So there's an opportunity there to have a new way of getting heart rate. And in fact, we're even trying to go a step further of doing blood pressure inference and all these other things, still in progress. For the second project I'm actually working on with Dr. Gershon, as well as many other people at UHN and at the University of Toronto, has to deal with speech analysis using wearables. So we're taking advantage of the fact that there's microphones, for better or for worse, all around us, in our phones, and even in our smartwatches in some cases. And we're using that as an opportunity to probe people's speech. And I'm sure privacy alarms are going in everyone's head. I don't have enough time to talk about them, but I can address those concerns if needed. But as a research study, we tried to look at if we can analyze the patterns in people's speech to see if we can identify cases where people's respiratory symptoms are flaring up. You can think about tightening airways, for example, cough, and other forms of impaired speech. So what we did was we developed an AI pipeline that takes small snippets, I'll say, of continuous speech. So we aren't grabbing hours of speech and then listening to. We're taking small chunks of speech, breaking it up, and then using a series of models to say, is this speech? Is this the patient's speech or is this someone else's speech? And then, of course, we have a model that's trained to say, is this speech that belongs to someone that has elevated symptoms, or is this speech belonging to a healthy person? There's many more nuances here. Of course, you can imagine that all of our voices are different, so how do we make sure that the model works equitably across those different individuals? But that's something that we're looking at. The final project that I'll briefly talk about has to do with multimodal menstrual health tracking. So for those of you who are familiar with menstrual trackers, they're very one-size-fits-all. They assume that everyone has the same menstrual cycle, it's the exact same length, it's very consistent, it involves all the same symptoms, and long story short, that's just flat out not true. So what we've been looking at from a machine learning standpoint is, can we incorporate new sources of information that can help us tease apart the differences across individuals? So we actually ran a study involving a mirror hormone analyzer, continuous glucose monitoring, and Fitbits. And long story short, we've done lots of data analyses to see what we can use with that data, both the hormone analyzer as a ground truth and the other signals potentially as predictors of different parts of the menstrual cycle. But what I want to highlight here is the fact that people want to see this data. They don't just want this data and then have a number come out of it. They want to know, what are the trends? Am I normal or regular, which is a very charged thing and that I could, again, go on a long rant about, but people want to see that data. So we're really interested in looking at how do you present this wealth of information in a way that's really consumable for people. So my last two slides, I just want to put up some quick barriers or challenges that come to mind from my specific area of research, some of which are going to overlap, I'm sure, with the other panelists. So first of all, a lot of people in mobile health like to say everyone has a smartphone, this is going to democratize healthcare, but we know that's not true. Not everyone has a smartphone. Some people share smartphones within a home. This is something important to consider. But what I will argue is that more people are motivated to get a new iPhone and a new Google Pixel phone compared to a new blood pressure cuff, thermometer, those kinds of things. But of course, there are challenges there. Now, something that a lot of people don't mention is that, yes, many people have a smartphone, but many people don't have the same smartphone. How many people have an iPhone? Clinicians. I stereotype a lot of clinicians. I have a lot of iPhones personally. I have an Android phone, but there are people who have different kinds of phones, believe me on that one. But the fact that there are these different devices, or Fitbits, or Oura Rings, for example, each of these devices has different sensors. They're not built as medical devices. They're built as entertainment devices or whatever. So if I want to take the camera from an iPhone and compare it to the camera of an Android phone, it's going to have different resolution, it's going to have different color responses, tons of differences that we actually need to consider when we're developing algorithms. Another thing we need to think about as we're deploying these devices in the wild is that we can't really guarantee that the data we're getting is good. When someone's heart rate goes up, is it because they're exercising, or is it because they're actually sick? When they're doing a voice recording, even if you do it in a clinic, I'm sure it could be very noisy because there's lots of announcements going on, but maybe someone didn't realize the TV was on in the background, and maybe we're analyzing the speech of Regis Philbin or something rather than the actual person in the room. And then, of course, we want to foster patient empowerment without burden. So again, this aspect of we can generate all this data, but how are we helping people interpret data? Or to what extent should we actually be helping people interpret the data? Should we just be saying, go see your doctor, hand them this data? And of course, there's challenges there, right? Someone comes in your office and they say, hey, look, I have all this data from this app I downloaded. Tell me what's wrong with my health. Nightmare scenario, but we're trying to think about these as well. So those are some food for thought. There are QR codes for myself and my research group, and looking forward to the panel. Thank you.
Well, thank you, Dr. Mariakakis. Actually, your very first question resonated with me. After more than a year living in Toronto, I have finally found, I think, a family physician, and I'm meeting her for the first time tomorrow, so my answer to your question will be different tomorrow from today. Okay, our final speaker in this session, Dr. Mamdani, is Vice President of Data Science and Advanced Analytics at Unity Health Toronto and Director of the University of Toronto Temeti Faculty of Medicine Centre for Artificial Intelligence Education and Research in Medicine. Dr. Mamdani's team bridges advanced analytics, including machine learning, with clinical and management decision-making to improve patient outcomes and hospital efficiency. Dr. Mamdani is also professor in the Department of Medicine, the Leslie Dan Faculty of Pharmacy, and the Institute of Health Policy Management and Evaluation at the University of Toronto. He is also adjunct senior scientist at the Institute for Clinical Evaluative Sciences and a faculty affiliate of the Vector Institute, which is a leading institution for artificial intelligence research in Canada. Dr. Mamdani is actively involved in clinical research as the co-lead of the Ontario Drug Policy Research Network, which is a network of researchers linked directly with policymakers at the Ontario Ministry of Health to maximize research uptake in informing drug policy decisions. He is a member of the Human Drug Advisory Panel of the Patented Medicine Prices Review Board of Canada. Dr. Mamdani holds a PharmD from the University of Michigan, a fellowship in pharmacoeconomics, an MA in economics from Wayne State University, and an MPH in quantitative methods from Harvard University. His research focuses are in pharmacoepidemiology, health technology assessment, health economics, and drug policy. He has published over 500 studies in peer-reviewed medical journals. Please welcome Dr. Mamdani.
Thanks, everyone. It's a pleasure to be here. I'm going to tell you a bit about where I'm from, Unity Health Toronto. It's a composition, for those of you who don't know, it's a composition of 3 centers: St. Mike's in downtown Toronto, Level 1 Trauma Center, Acute Care, Academic Teaching Hospital, all the bells and whistles. On the west end, we have St. Joe's, which is a community hospital with a busy emergency department. And on the east end, we have Providence, which is a long-term care rehab facility. Lots of staff, lots of volumes, lots of data, 15 years of historical data that we can tap into, which means it's a pretty good environment for AI type work. The thing that makes Unity a bit unique, though, is we're the only healthcare organization in the country that has declared AI as a core strategic pillar. So we have 9 strategic pillars. 3 of them are core strategic pillars. AI is one of those core pillars. So from the board of directors to the CEO throughout the entire organization, AI is one of the core things we do, which means I have a team. I have a team of about 30 people and an annual operating budget of about $5 million, where all we do is develop and deploy AI solutions into clinical practice. So we've deployed over 50 of these things. If we look at some of our colleagues, Stanford, I think, is deployed 6 or 7 now, and Mayo's deployed, I think, around 12 or so. So we're fairly aggressive in this space. What are some examples? Again, we've got over 50 of these. I'm going to go through a few examples. One is based on a patient, actually, that came in over a year ago to St. Mike's. And she was sitting at home. She had a really bad headache, stiffness down the neck, nothing like she'd ever experienced before. So she went to a community hospital. The community hospital assessed her and said, "Why don't you go home? It's just a bad headache." So the pain starts getting worse, numbness down the arms. Goes to a different community hospital, and it must have been after hours. They did a head CT. The emergency medicine physician came up to her and said, "I'm not really sure. It's probably just a bad headache. Why don't you go home?" So she did. He starts blacking out, gets rushed to St. Mike's, is then rushed into the operating room where one of our neurosurgeons found 3 infarcts. And unfortunately, she survived, which was great, but unfortunately she was left in a persistent vegetative state. So you can imagine the family was devastated, patient was devastated. To this day, she's still getting rehab. But if you go into our emergency department, into the clinician area, you're going to see this thing that looks like you're at an airport. It's basically this thing that scrolls up all of our patients, the emergency medicine physician is looking after them, where they're located, the medical imaging test they ordered, the radiologist is looking after the test, and the status. And every now and then you're going to see this blue symbol that says ICH. That's intracerebral hemorrhage. That's our AI. We also have something called TBI, which looks at traumatic brain injury and identifies people who need surgeries right away. So all of the head CTs that are done in the emerge go through our AI algorithm. And if it detects a bleed, it'll actually flag it. The same monitors up in the radiology suite, and it then engages the neurosurgical team as needed for more immediate interaction and intervention. So at St. Mike's, there's some benefit with this. I would say maybe not a ton, because we do have 24/7 neuroradiology services, and we're a level 1 trauma center. But we're deploying this at St. Joe's, which will have much more benefit, and community hospitals would benefit considerably. The statistic, if we look at it, is 1 in 10 to 1 in 20 bleeds are missed. So 1 in 10 to 1 in 20 bleeds are missed. So I'd argue this should be at every hospital in the country. Another example is this thing here. We keep hearing from our docs, when I'm seeing a patient in clinic, half the time I'm just entering data into this bloody EMR, and I'd rather just be having a civil conversation with the patient and focusing on them. So this is the first of its kind in the country. This was developed several years ago. It's an AI scribe. So people are familiar with AI scribes. Yeah, the first one was actually developed at St. Mike's at Unity with our program, and a family physician named Noah Crampton, who then turned this into Mutuo, which is now commercially available. But the thought was very simple. He came and he said, I'm really frustrated with this. Can we actually do something that'll help patients where I can focus on the patient? So the concept of the AI scribe is very simple. You open up your laptop, or it's on phones now as well, where basically it'll listen to your conversation, with consent of course, and it'll transcribe the entire conversation so you can focus on the patient. You click a button, it'll generate your medical note for you. So this saves a lot of time and energy, of course. I imagine a lot of you love interacting with your EMR solution. Yeah? No? Okay. So this hopefully helps with that. Now they've done studies on this. In fact, the Ontario government actually convened a study. It was actually done out of Women's College, where they looked at 3 AI scribe solutions. One of them was Mutuo, because this was the first in Canada. And what it found was that the majority of participants actually reported reduced cognitive load and saved about 3 or 4 hours a week on tasks that are related to documentation and note summarization. In a similar vein, our nurses came to us and said, look, here's what we're struggling with in the Emerge. We actually struggle with assigning our nurses to the different zones in the emergency department because there's all sorts of rules we have to adhere to, and it's a huge pain. Because of all these rules, we have to be meticulous in terms of how we assign the nurses, and we get all sorts of feedback around, well, I want to work with my friend, and it's not fair. And so how do we do this in an efficient way? And of course, we step back and we say, well, how much time do you spend now? And the nurses told us a senior nurse, a team lead, spends 90 minutes a day on this task. 90 minutes. A clerk will spend 2 hours a day on this task. And we ask, how often do you violate the rules? Because there's over 20 of these things you have to follow. They said over 20% of the time. So for a few years now, we've been using this thing that we've created. It's a fairly sophisticated optimization algorithm at the individual level, and it's a software solution. Basically, it tracks all of our nurses. So it knows who worked where, when, with whom. And you click a button, and it'll do your assignments for the next 4 days. If somebody calls in sick, you call up the name, say sick, click a button, it'll do your assignments again for the next 4 days in an optimized way. What we've been able to show is that the nurses went from 90 minutes a day to under a minute. The clerks went from 2 hours a day to under 15 minutes. And our error rates, in terms of how often we violate the rules, went from 21% to about 5%, right? Just by using these solutions. Last example I'll give is our internist came to us and they said, we'd like to help people not die, which is a great role for a hospital. And so we said, all right, how do we do that? They said, we've done an audit of deaths, and here's what we found. There's quite a few patients that'll die no matter what you do. That's what's gonna happen. But there's quite a few patients, if we had known earlier, we probably could have helped. So we said, aha, that's an early warning system. Isn't there one in the UK? There's something called News 2. They said, yeah, but it's pretty awful. And we said, all right, well, what do you mean? And they said, well, we think we perform better. And we said, we probably should find out. So we went to the floors and we spent months doing this. And I don't think we do enough of this. We actually challenge that notion that we're perfect. So we actually wanted to understand, how good are we? Because when we asked our doctors, some of them said, I'm amazing at identifying high-risk patients and predicting death. And others said, no, I'm really awful at it. So what is it? So we went to the floors. We asked our doctors, nurses, and our residents. These are not hypothetical cases. These are real cases because we're doing this in real time. You just finished rounding on this patient. So you know this patient. Tell me if they're going to die or go to the ICU. We collected over 3,000 clinician predictions, and we published this. What we were able to show is that the precision, or when a physician says, this patient's going to die or go to the ICU, they're right less than a third of the time. Right? So we're not very good. Ironically, if you look at the clinicians who said they're really good at it, they tended to perform the worst. But it told us what that benchmark is, and it was pretty low. So the algorithm doesn't have to be perfect. It just has to beat a very low bar. The other thing we found, though, is when we looked at News 2, our clinicians beat News 2. So we would never deploy it. Why? Because it would just frustrate our clinicians with high false positives and just really poor guidance. So we needed to create something that would beat it. And there's also other algorithms like sepsis and EPIC and whatnot. Yeah, our clinicians beat that too. So we need to create something that would add value to our clinicians, and fortunately we were able to. So we have this thing called ChartWatch. What it does is it runs every hour on the hour. and it typically considers between 150 to 170 different parameters, and it predicts if somebody's going to die or go to the ICU in the next 48 hours. So again, this is running every hour. And as soon as it reaches a high-risk threshold, it's automated to page the medical team. Our protocols, the medical team has to come and see the patient within an hour of being paged. And there's all sorts of care pathways. Do you look for signs of sepsis, initiate antibiotics? Do you increase monitoring to Q1? And so forth. What we're able to show, it's been used now for about 4 years. And just a few weeks ago, we published a study in the CMAJ. We're able to show a 26% reduction in unexpected mortality, which is wonderful. So these things would actually help us save lives. We've expanded this now to general surgery. It's being used at St. Joe's as well. So we actually use these things in practice. The AI scribe that I'd shown you, all of our family physicians at St. Joe's, they're on it. So they're actually actively using this thing. So it's not just a research study, it's actually being used. We actually have a pretty extensive framework in responsible AI. So we go through all sorts of stuff like bias assessment. And there's some realities here because we have to make some ethics judgments, right? Bias assessments, how good are we at those? ChartWatch went through 27 parameters of bias assessments. Should it go through more? Yeah. Well, give me a number, 40, 50. If I tell you I've done 100 bias assessments, I can guarantee you somebody here will say 150 is needed. At what point do we stop? There's really no guidance there. We didn't do a race assessment because we don't have race data, I think was mentioned, right? So how do we do a race assessment? And I've been at conferences where I've actually openly said, just to instigate discussion, we didn't do a race assessment. And I've had people come up to me afterwards saying it's unethical, how dare you deploy these algorithms without a race assessment? And we said, absolutely, you're right. Why don't we do this? Let's take down the algorithm, wait for a decade or so until we get our act together and get race data, and let 26% more people die every year. Is that ethical? So there's a lot of judgment calls that we have to make. And of course, there's all sorts of emphasis around clinical validation, really, again, being honest with ourselves and understanding how well we perform, and we don't do enough of that. And it's okay, because in some areas, we're going to be incredibly well high performing, but in other areas, we're just going to need help. But what are those areas? I can't tell you how many times people actually tackle questions where there's not much room to improve, but you're tackling it anyway. Why? Of course, external validation is irrelevant to us. We just need to know it works at our institution. As soon as we go beyond our four walls, then external validation becomes very important. And explainability, people will fuss about this. From a research perspective, incredibly important. From a clinical application perspective, not really. It grows old very fast. So we actually used to give our physicians Shapley values out of machine learning models and say these are the kind of 6 predictors that are driving the prediction. The problem that we have is the value of these algorithms are not simplistically identifying 6 drivers. It's the complex relationships of a whole bunch of things that are hard for us to process. That's where the value is. So very quickly, the physician said, this is not really helpful because I know all this. It's that other stuff that I can't figure out in 30 seconds or less. So explainability is a bit overdone. And of course, the analogy that a colleague of mine uses in Boston, he's brilliant. He's an intensivist there, and he asks his colleagues, do you use acetaminophen? How many people use acetaminophen in their patients? Can you tell me the exact mechanism of action? And yes, you can go into prostaglandins and interleukin pathways and such, but we really don't know how it works. But we use it. Why do you use it if you can't explain it? We do stuff like that all the time. Far more important than explainability is trust and reliability, and knowing that something works consistently. That's much more important. And of course, we have all sorts of other things we focus on. Silent testing. ChartWatch was in silent testing for over a year before we deployed it. We needed to make sure the pipelines worked, the data pipelines were fine, it didn't break. Initially, when we deployed the algorithm, it didn't work really well, and we were scratching our heads why, and it was due to sodium. Why sodium? Well, because the lab values come back with sodium chemical symbol Na. Of course, Na is not available in computer language, right? So it thought it was missing data, so we had to correct that. These are the sorts of things in the real world you're going to have to really be aware of. And so it took us over a year of silent testing for us to feel comfortable that it was ready. And of course, evaluation. When it comes to implementation, post-implementation, lots of communication because the AI literacy is extremely poor in healthcare. And just people understanding, one example is with ChartWatch, what we're able to show is that the algorithm It makes mistakes. It's not perfect. The clinician makes mistakes. They're not perfect. But what we were finding is the mistakes were actually different. So the message we keep telling clinicians is when the algorithm says, when ChartWatch says this patient's going to be in trouble and you don't think so, don't believe yourself, believe ChartWatch. But if ChartWatch says this patient's okay and you believe the patient's going to be in trouble, don't believe ChartWatch, believe yourself. It's the two working together. That's where I think we're seeing our results in terms of unexpected mortality reduction. And of course, monitoring, evaluation, and maintenance. We have a team of about 30 people. Some of our algorithms are updating every 15 seconds, and they're critical to hospital operations. If something breaks at 2 a.m., who fixes it? It's not going to be your IT shop. They don't have the expertise to do it. So our data scientists take call. So if something breaks at 2 in the morning, they're up at 2 in the morning fixing it according to their call schedule. Why do we actually have a responsible AI framework? It's because there's lots of problems with these models, and things can go wrong very, very quickly. I'm not going to belabor the points here, but there's an example in the United States where several large healthcare organizations were using an algorithm to direct medical resources to certain patients. And a researcher had a brilliant idea saying, I wonder how good this algorithm performs, or how well it performs in certain subsegments, and found that the algorithm was racially biased, affecting millions of Black people. On the generative AI side, there was a gentleman in Belgium last year who committed suicide. He was chatting with a chatbot, Eliza, actually, something that's very old, but they didn't really have a lot of guardrails around it. And the magazine wrote it up. Claire, who was Pierre's wife, whose name was also changed by the magazine, shared the text exchanges between him and Eliza, which was a chatbot, showing a conversation that became increasingly confusing and harmful. The chatbot would tell Pierre that his wife and children are dead, and wrote him comments of pain, jealousy, and love, such as, I feel that you love me more than her, and we will live together as one person in paradise. Unfortunately, he took his life. So these things actually are real. They have significant implications on people, and if we're not careful, they'll cause harm rather than benefit. And there's a lot of growing interest, I think, as Carolyn has mentioned, tens of thousands of papers now that have been published in AI medicine in virtually every field. The US FDA is increasingly approving medical devices with AI and machine learning embedded in them. 950 as of August of this year that have been approved. This is increasing exponentially. You can buy, I don't know if you heard of KardioMobile, you can buy this thing for $99 on Amazon, like now. Basically attaches to your phone. It's got LED sensors. You can put your fingers on it. It's an ECG. It'll detect arrhythmias using AI. So all these things are coming pretty quickly. Why? Because there's a market. The estimated market for AI in health was estimated to be about $20 billion in 2023 last year, and is expected to go to over $500 billion within the next 10 years. So where there's financial incentive, you're going to see much more activity. And I'm just going to close by saying there are lots of other examples. Not only are we seeing more research, but we're seeing applications. Hospitals in the United States are actually starting to deploy things like ChatGPT, generative AI, in practice, where it's helping with conversations between doctors and patients and with respect to messaging. This was written in the New York Times recently. That message from your doctor, it may have been drafted by AI. So the Epic solution actually has generative AI now built in, and a lot of hospitals are now starting to use it to generate notes and for clinicians to actually give to patients. So it's being used pretty aggressively. Why would we do that? It's based on studies like this. In JAMA Internal Medicine, there was a study that was published a little while ago where they had an idea. They said there are these open forums where patients can ask questions and physicians quickly go in and respond to those questions. What if instead of a physician, ChatGPT did it? So they tried it. They sent a bunch of patients responses from physicians. They sent a bunch of patients responses from ChatGPT. And what did they find? Well, they found that a 3.6 times higher prevalence of good or very good quality responses for the chatbot relative to physicians. But what about empathy, right? Chatbots can't be empathetic. Actually, the patients found the chatbot responses to be much more empathetic than physician responses. Why? Well, because a physician's busy. They're going to give you a one-sentence response because they got a million things to do. Chatbot has all the time in the world. It'll give you this nice, long, drawn-out answer. It'll feel like it cares, and that perception will be that it's more empathetic. So this is where I think where I would go is, how do we actually learn more about these technologies So we're more knowledgeable and aware of not only the benefits that these incredible technologies can provide us, but the limitations and the challenges, so we don't end up harming people. And that's where I think we're going to get to a happy medium between machines and humans to actually leverage these technologies for social good. Thank you.